Okay, let's get started. I want to go to page 266, 266. And before I start, I forgot, let's just refresh or remind about the schedule. No changes or anything, but today is our last class of the semester. You can congratulate yourselves. It's been a long semester. You did a great job. After the final, okay. Yeah. And then, so tomorrow's test 3. We've been through what's on there. We'll finish it up today. It's just a few more things. So tomorrow's test 3, 65 questions, usual. And then for those here in this room, the Kaiser students, your final exam is Tuesday, next Tuesday at 8 o'clock, right? 8 o'clock in the morning. And as I mentioned before the Thanksgiving break, the final exam is 100 questions. And it's just literally the exact questions I lifted off the first 3 tests to try to get you to go back. And I put 4 or 5 new ones in it. But not new information, just change the wording a little bit or something. So there's no new material. In other words, just I want you to go back and review what we've been through. And then the next time we meet will be Tuesday, January 9th. Next semester we meet once a week for 3 hours from 7 a.m. to 10 p.m. 10 p.m. The whole semester in one day. From 7 a.m. to 10 a.m. LA time. You can do the math, time changes across the country. Yeah, Tuesday 7 to 10. We meet January 9th. Don't forget to bring your new workbook that I handed out. For those in the remote sites, I've sent your final exam to the faculty members, and you can arrange with them to take it whenever is convenient for all of you at your particular school. After today, since it's the end of the classes, you'll be all set to go. So arrange with your faculty preceptor for this class, and you can take the exam whenever. I've also shipped all the books out to the other programs. I checked the tracking numbers this morning. There's still a couple on the Far East Coast who won't receive them until tomorrow, but most of the programs have gotten them already. And so the point is you'll all get them this week sometime. You'll have them in plenty of time for January 9th, so please bring your new Pharm 2 workbook in with you then, because that's what we'll use. We're going to delve right into muscle relaxants is our next topic, and I'll be ready to go. I think that's everything. Did I forget any questions? Okay, let's wrap it up then. Page 266. 266. We started the last class before the Thanksgiving holiday with doing the non-narcotic analgesics. So let's I can backtrack a little bit. I mentioned primarily there are 3 categories. 2 of the categories are one drug. Aspirin is one, acetaminophen is one, and then all the rest are called NSAIDs, and we'll list those and look at those a little bit later. And they're all used primarily for 3 reasons. Number 1 is analgesic, and they're all analgesic. Number 2 is to treat fever, they're all antipyretic. But number 3 is an anti-inflammatory drug, and they're anti-inflammatory except for Tylenol or acetaminophen. And that's right there on page 266, and I typed it in capital letters. So the only one difference is that acetaminophen is not anti-inflammatory. Then we went to the next page and talked a little bit about each one, some of their differences, and so on, and we're going to continue that today. But I went to, let's go to page 272, and the point was, number one, their primary mechanism in the body, all the NSAIDs, aspirin, acetaminophen, and the NSAIDs, their primary mechanism is to block what's called cyclooxygenase enzyme in tissues, and cyclooxygenase is abbreviated as COX, C-O-X, and there's two isoforms of COX, COX-1 and COX-2. COX-1 is a constituent enzyme, and medically that means it's always there in the tissues. COX-2 is an induced enzyme, and that is when there's tissue damage, the tissues form and release COX-2 enzyme as a way to address the inflammation and the tissue damage and trauma. So COX-2 is inducible and COX-1 is constitutive. All of the NSAIDs block both COX-1 and COX-2 except for one drug. There's only one drug on the market that does only COX-2, and that's Celebrex. We'll go into that a little bit later. And it's a pill, so we don't really use it anesthesia-wise. But the thing was, and I talked about it, that first of all the studies they do on NSAIDs, they usually do it, or almost always do them on arthritic patients. Number one, because it's a treasure trove of people. There's tens of millions of people that have arthritis, so there's no shortage of subjects. Number two, most of the people who take these on a chronic basis are arthritic. That's why they take them. And you'll see them almost daily in your practice in the hospital. You're always going to have oldies coming in with arthritis, and they're taking NSAIDs, and you'll have to address that population. Now, one of the major side effects, and we'll go through them all today, one of the major ones is GI bleeding. It's not something anesthesia worries about, but for those who take pills every day for the rest of their lives, it does become a problem. And the GI mucosa, mucus formation, and some of the integrity of the GI mucosa is due to prostaglandins and thromboxanes and so on that are produced by COX-1 enzyme. So if you inhibit COX-1, you inhibit the protection of the GI system, and therefore you end up with GI bleeding. So one of the reasons why aspirin and acetaminophen and the NSAIDs are notorious for causing GI bleeding is that by blocking COX-1, they're interrupting the protective coating, one of the protective coatings on the GI system, therefore you can get some GI bleeding. COX-2 does not do that. So they came up with selective COX-2 inhibitors in order to try to keep the beneficial properties of the NSAIDs, that is antipyretic, anti-inflammatory, and analgesic, and then not have the GI bleeding part of it that comes with COX-1. And that's generally successful, a little bit. It's not perfect. But Celebrex, the only COX-2 specific inhibitor, is more friendly to the stomach. The problem is a couple other ones that were produced. Vioxx is, of course, the big one. It was in the news for many, many years. Probably you're too young to remember, but maybe 10 or 15 years ago, and it was pulled off the market, and there was tens of billions of dollars worth of lawsuits, and it was a total mess because people came up with cardiac problems and valve problems and died from heart attacks and so on, attributable to the COX-2 blockers. The only one that didn't do it, it wasn't class specific, it was drug specific. So in other words, it wasn't that it was a COX-2, it was just specific to certain drugs. And Celebrex did not do that, and that's why it's still on the market. Yes?
Isn't meloxicam also COX-2?
I don't know. Not that I'm aware of. I'll have to look it up, to be honest with you. I didn't know that. As far as I know, it's not. We can look it up later on. It's in here. So anyways, we kind of went through that. Now, arachidonic acid is derived from the scavenging and saving of the useful parts of cell membranes when they're degraded and secreted. You know, you pee them out, turn over cells in the body. The cell membranes are scavenged and you save some of the important parts of them, one of them being arachidonic acid. Arachidonic acid is then acted upon by the cyclooxygenase enzymes to produce various prostaglandins and so on. If you look on page 273, you'll see that drawn out. Maybe I'll go on the camera and point. Yours?
Yep.
Somebody didn't give it back. It wasn't me. All right, so there's the cell membrane broken down. It's acted upon by phospholipases, and we're in this microphone. I never turned it in. Phospholipases. It's broken down into arachidonic acid. Then cyclooxygenase COX-1 and 2 breaks it into all the various prostaglandins, thromboxanes, and so on. So if you block COX-1 and 2, you prevent the production of these autocoids and you can get the effects. Obviously all three NSAIDs are not identical. Since acetaminophen doesn't have an anti-inflammatory effect, it must have some difference in what it does compared to the other two. But we just kind of, in general, because we're not really sure what that is, we say that they all block COX-1, which they do, and COX-2. But there's obviously some, nuanced differences that we're not talking about. All right, so then we went through this little article about Advil versus Tylenol, page 274. And basically, I'll tell you what it comes down to. If you have a trauma, you sprained your ankle, you got tissue damage of some kind, and you've got swelling, then you might as well take Advil because it's anti-inflammatory, as well as analgesic. If you just have a headache or something that's not involving inflammation, just pain somewhere, then Tylenol would be probably effective as well, because it's safer. Tylenol is very safe, rather than Advil. And some people just have a better response to one or the other. There's just no rhyme or reason to it. But so it's a kind of a trial and error thing, and I'm sure most of you, if not all, have had a chance to take one or the other or both, and you have a preference for that and so on. So they go through these. On page 275, they compare the differences. And as far as an antipyretic, of course, Tylenol is the most famous and widely used one in the world for treating fever, especially in kids. Eases pain, they both do it. Inflammation, only Advil or ibuprofen. Toxicity, there's there's more toxicity to the NSAIDs than was previously thought, and we're going to talk about it today. The big toxicity for Tylenol, of course, is liver failure. And that's the number one cause of liver failure in the world, is overdosing with Tylenol. And it's not overdosing as in drug addiction overdosing. It's accidental overdosing, because people are taking over-the-counter medicines or taking Tylenols on purpose, and they just take too many, and then they end up with some kind of liver damage. I'm going to show you how that works today too. And then side effects for both of them are very minimal. For acute dosing like we do, they're almost non-existent. These are probably the safest drugs we deal with. No side effects are greater than placebo. Now, of course, there are side effects if you're taking them chronically, like an arthritic patient, and that is GI bleeding and then platelet, the antiplatelet effect and so on, and we'll get into that today. So I think that's kind of what I did the last class, so let's pick it up there. And let's go to page 280, page 280, and I put a list in there. This is from family practice book, medical book, and it's just a list of all the different NSAIDs. The first one being acetaminophen, of course, is Tylenol. Acetylsalicylic acid is aspirin, of course. And then all the rest of them are classic NSAIDs. Celecoxib is Celebrex, that's the COX-2 specific. And then you can see all your friendly drugs that many people have taken. You've given them to patients, you've taken them yourself. Naproxen is one of the popular ones. That's Aleve, long-acting form of it. It's ibuprofen, of course, is kind of the prototype or granddaddy of them all. And so there's all kinds of drugs that you are familiar with. Ketorolac or Toradol is popular in hospital use because it's injectable as both IM or IV injection, and that's pretty convenient. We're going to talk about that as well. So there's just a little bit of a list of some of the drugs. Now, so let's start up for today and by going to page 278. This is a new thing that's been talked about a lot recently. You can see this is from the 278, the British Medical Journal, just in May of this year, and they came out with a big study in Britain that said that people who are on these drugs chronically have a higher risk of MI. So we think of them as relatively innocuous, but we're talking about arthritic patients and, again, people who take them years at a time. And now they have a higher risk for acute MI in a real-world use. So let's take a quick look at this. This is a chart review or whatever. They looked at methods. 8 eligible sources were sourced from prescription databases, etc., in a general and elderly population, and studied selective COX-2 inhibitors, as well as traditional NSAIDs. Now this is British, so they have another one in Britain than we have here. And they looked at MI, and we can jump to the conclusion on the next page. And the conclusion was, all NSAIDs, including naproxen, were found to be associated with an increased risk of acute MI. The risk is with Celebrex or Celecoxib, the COX-2 specific one, is comparable to that of traditional NSAIDs, and what was lower with rofecoxib. That's not available in the United States. Risk was greatest during the first month of NSAID use and with higher doses. So there's a dose-response relationship, which we'd expect. The higher the dose, the more frequent, and it usually happens in the first month or two after they're on it. So again, it's really an anesthesia-specific thing, but it's just something to be aware of that's out there. Now, let's look at Tylenol. Let's go to page 281. This is, and we'll do this briefly, but just to mention, since this is the number one cause of toxicity from Tylenol, and this is world famous in the pharmacology world. It's been well known for decades. So here it is. When you take Tylenol, acetaminophen, it can be metabolized a couple different ways. It can be conjugated with glucose, so there's a glucuronide conjugate that's non-toxic. It can be conjugated with sulfonic acid or sulfate, and that's not non-toxic. And it's broken down by cytochromes 2E1 into what's called, this is the toxic metabolite. It's called NAPQI. and it's a well-known toxic metabolite of acetaminophen. Now, if you have small amounts of it in the body, then it can be quenched or scavenged by glutathione, which is in the liver, the natural product in all our livers. And the glutathione will detoxify NAPQI, and it'll produce non-toxic metabolites. However, if you produce more NAPQI than the body can handle, and the FDA says that's excess of 4 grams a day. So if you take more than 4,000 milligrams a day, which people do, then you could produce an excess of this toxin. You don't have enough glutathione to scavenge it, and you're going to end up with liver damage, drug-induced liver damage. So it's a pretty simple mechanism. Classic drug causing some tissue damage of some kind. It gets metabolized in the liver by cytochromes to a toxic metabolite, and if you exceed the body's ability to quench that metabolite, scavenge it, then you get toxicity. That happens with hundreds of drugs. This is the famous one. Now, if you want to look on the next page, page 282, and this is from June of this year, so it's a pretty recent article. This is from the medical letter, and they talk about Tylenol overdose. This is a very prominent problem in ERs and so on, because people come in with toxicity from Tylenol, and they have to be treated. So let's take a look. They have a new formulation of drug to treat it. This is page 282, the medical letter. The FDA has approved an effervescent tablet. So you drop it into water and it fizzes up. Formulation of acetylcysteine to prevent or lessen hepatic injury after acetaminophen overdose. Acetylcysteine has been available for years as an IV solution, an oral solution for the same indication, but the oral solution's use has been limited by the fact that it smells and tastes bad. People don't want to drink it. Acetylcysteine prevents hepatotoxicity by replenishing glutathione and detoxifying NAPQI, the highly reactive metabolite of acetaminophen. So it's very simple. It's just a glutathione provider or adding to it. Acetaminophen is one of the most common drugs taken in overdose. It's available in single, immediate, and extended release formulation. It's a part of many cough, cold, allergy, analgesic products, and the overdose can cause serious or fatal, often, hepatotoxicity or severe liver damage if greater than 4 grams of the drug is taken within a 24-hour period. Many studies have shown that acetylcysteine is generally effective in preventing acetaminophen liver damage, renal failure, and death if it's given within 8 to 10 hours of an overdose. It's less effective if longer time has passed, which makes sense. The new formulation has a lemon mint flavor and is more palatable than the oral form. So in conclusion, the new acetylcysteine tablets appear to taste better than the oral solution. The adverse effects and such are similar. So you look at in the table, the generic form is $367. The new form is $755, and there's a generic form, another generic form, and that's significantly less. So it's going to cost you more, but it's worth it. I wanted to spend it on me. It was me, so spend the $700. Save my liver. Okay, so that's a little bit about Tylenol liver damage. Yes, question.
So, from what I'm understanding of this isn't gonna, like, if a patient takes this after they've had all of their Tylenol or something, or even if we move away from how expensive this is, as someone who's trying to manage pain chronically and takes a bunch of different Tylenol products, could they just be drinking this, as a part of their regimen to kind of boost their liver? Because it doesn't work like Narcan and competitively bind to make it so that they still get the pain management effects of Tylenol with this. It's just helping
Yes, it
boost
doesn't.
their liver so they don't
Yes,
get
it
damaged.
does not reverse the effects, the pharmacologic effects of the drug, but it reverses the toxicity of the metabolite.
So maybe after it's been out longer, it gets cheaper in some other way, like people could start taking this as part of their pain management regimen.
They could, and so your reasoning is correct.
Okay.
The difference is, usually you don't have to take more than 4 grams to get the effect.
Yeah.
You could easily have a nice life taking Tylenol if you kept it around 2 grams a day. So, and that's why, and you're right when you mention this, that's why they say accidental overdose most of the time, because people just don't know. They're taking products, they don't know there's Tylenol in them, then they're taking Tylenols on top of that, and then the next thing you know, they got problems. So could they? Yes, they could. Take that as a prophylactic treatment against the toxic metabolite, but in a practical sense, you could just cut the dose down.
Yeah, if they knew they were doing that,
If they
know
knew.
if they needed this product.
Correct.
Gotcha.
Exactly right. Any other questions? Okay, so let's go back to page 267 and just do a quick review of some of this. I think I wrote this, I'm not sure, can't remember. NSAIDs, including aspirin, I'm on page 267. 267. NSAIDs, including aspirin and acetaminophen, are a diverse group of analgesic compounds with different kinetic properties. Primary mechanism is through cyclooxygenase inhibition and blocking the synthesis of prostaglandins. The discovery of at least 2 COX isoforms, 1 and 2, with different functions, whereas COX-2 has pain, inflammation, and fever, that blocking, but it doesn't do the GI or the antiplatelet effects. Used as a sole agent, the NSAIDs generally provide effective analgesia for mild to moderate pain. The number 1 reason we use them in anesthesia is what? Well, there's number 2 reasons. I'll give you the 2 top reasons. Number 1, they don't cause respiratory depression. You give them in recovery room, you're not putting the patient respiratory depression, and you can send them home. And number 2, they don't cause nausea and vomiting. And that's the 2 issues we have giving analgesia at the end of a case, or into PACU. Yeah, it'd be great. We can go into PACU and blast fentanyl into somebody and they're not going to have pain. The problem is they're not going to leave the hospital anytime soon, and they're all going to throw up on you. So, people are trying to avoid the use of that and do opiate-free anesthetics, or at least opiate-free for the last part of the anesthetic and then into PACU, so they can use other alternative analgesics, which of course we have with these. And we'll talk about the 3 IV ones here in a minute. So the big advantage, of course, for anesthesia, as I said, is no respiratory depression, no nausea and vomiting. And pretty moderate analgesia. They're actually pretty good for analgesia. They're not good for severe pain. If you have a Whipple, you have open heart, you got some major spinal surgery, you're on the table for 12 hours, getting 20 units of blood and having major surgery with 5 surgeons working on you, acetaminophen is not going to block your pain. You kind of know that already. But for the average outpatient surgery, which most surgery is, in a surgery center setting, in a minor procedure or whatever, just incisional pain or a small amount of pain, it's going to be fine. And the patient's going to be able to go home and it's safe with minimal side effects. The second to last paragraph on 267, the peri-op use of NSAIDs is associated with a number of side effects, including decreased hemostasis. So let's talk about this, all right? We mentioned it before. Here it is. Aspirin is non-competitive antiplatelet drug. So aspirin blocks platelets permanently. That's what non-competitive is, right? The only way you get your platelets back is make new ones. without aspirin in there. So in order to get the aspirin antiplatelet effect to wear off, the books will say it takes 7 to 10 days. What lab tests would you do to see if the patient, you're not going to do this, it's not who cares? But what if you're going to do a lab test to check the effect of aspirin on clotting, which one would you do? Platelets, you can do platelets, whatever. Bleeding time, right? Bleeding time would be an aspirin. All right, so 7 to 10 days, discontinue the aspirin. Now, here's the ticket. There's a lot of recent studies showing that it's stupid to discontinue the aspirin for this reason. People are on aspirin for a reason, primary prevention, like I am. Somebody who's had a stroke and takes aspirin every day. I don't want to stop taking my aspirin for 10 days prior to surgery, because that leaves me open to, and then many other patients who take it for, most people are on it for post-MI or cardiac reasons, and they don't want to stop taking it and they have some kind of a cardiac event. So it's almost routine. And I can tell you, I went to surgery, as you know, here's my little wrist surgery, a couple weeks ago here at Kaiser, and they advised me when I went for the pre-op visit, stop taking aspirin 7 to 10 days prior to surgery. And of course I didn't do it. I figured these guys got a Bovie machine, and if my wrist bleeds, he can always just in the meantime I won't have a stroke. So anyways, it's still very common to talk to patients and advise them to stop taking it. The new thinking is they should not. Let them stay on it. It's a minor antiplatelet drug. You can still clot. You can still do everything you need to do. And here's the situations that they can probably discontinue the aspirin. It's when they're going to possibly have a lot of bleeding and a closed space. And so those kind of procedures are this. Eye surgery. If you're going to have surgery in your eye, you don't want to have any bleeding in there. That's a closed space, and any kind of bleeding is going to have pressure, and it's going to be a problem. So eye surgery. Neurosurgery, intracranial. If you're having brain surgery, you don't need to have bleeding in there. And lastly, prostate surgery. So you're going to be hooked up to that Da Vinci and be given a prostate procedure because they bleed so much. They have so much bleeding that it's probably better to discontinue. So the current newest thinking is you can probably stay on aspirin except for the patients who are going to have ophthalmology, ocular surgery, not surface, but inside, intracranial surgery, or prostate procedure. If they're having them, sure, then I guess you can discontinue it. Otherwise, keep them on their aspirin. Question?
Is that regardless of dose? Like they're on 325 versus like 81 milligrams?
It doesn't matter. Yeah, it doesn't matter. It's not dose dependent. So either 325s or the little minis, the cardiac ones, either one. So that's that. Now again, you're going to go to work in the OR starting next week, and you're going to work with people that say discontinue the aspirin, and that's probably the most common thing you read in the anesthesia literature. But I think the newer thinking and many of the new studies that are coming out say that no, let's be a little more, instead of blanket rules, we stop taking drugs to everybody. Let's be a little more specific. I'd rather not have the patient have some event because I took them off aspirin for 10 days or whatever. Okay, the second part of that is the NSAIDs themselves, non-aspirin. So I'm talking about acetaminophen or ibuprofen or naproxen or the NSAIDs, that whole big list I just showed you. Then they have to be discontinued 24 hours prior to surgery. They're not non-competitive. They're competitive. In other words, they wear off, and that wear off in 4 half-lives. And for example, the half-life of ibuprofen is 3 or 4 hours, so it'll all be gone within 24 hours. So their antiplatelet effect, if they just don't take their dose in the morning of surgery, they'll be fine. That means the last dose would have been yesterday, so it's going to be worn off by then. All right, so that's the story. I'll say it one last time. Aspirin, it's been common wisdom, and probably, I think, it's still conventional wisdom in most anesthesia literature, that you should discontinue it 7 to 10 days prior to surgery to prevent excessive bleeding. However, if you want to be a real modern, thoughtful, normal CRNA, think which side do you think I fall on? Then just discontinue it on those procedures, eye, intracranial, and prostate. The NSAIDs, you can stop them if you want. It's not that critical. If somebody's taking it for arthritis, they can skip their morning dose and they're not going to have an arthritis attack or something like that. So it's not that big of a deal. So they can just stop taking it the morning before, don't take it the morning of, and they'll be fine. Does that make sense? Okay, then back to page 267, second last paragraph. So there's a number of side effects. They talk decreased hemostasis. We talked about that. Renal dysfunction. The NSAIDs all cause, because of their blockade of prostaglandins, they can all cause a deterioration of renal function. Prostaglandins are necessary to maintain normal renal function. So people that have renal disease, that's a relative contraindication to getting these drugs. I would not give Toradol, I would not give acetaminophen IV or ibuprofen IV to patients with renal disease. All right, are they going to die? Probably not. All right, but it's just not a good idea. It may cause deterioration of renal function, and you don't need to do that to somebody post-op. And again, we're giving these drugs at the end of surgery or in the package. That's,
Even as a single dose, not recommended.
you know, it's probably, like I said, it's not going to kill them, but I wouldn't do it anyways, because something that's not good for the kidneys and you give it to someone with bad kidneys, it's probably not a good idea. Is it going to matter that much? I would say probably not, but I don't want someone blaming me for, you know.
So just IV Tylenol?
Well, that's the way we use it.
Okay.
So, oh yes, if you're going to give pills or something, I wouldn't do that either, but we give it IV, so that's the reason I mentioned it. GI hemorrhage, of course, obviously, that's a problem. And then I mentioned before, they have a definite deleterious effect on bone healing and osteogenesis. So we don't use them in orthopedic patients. So all the NSAIDs, the ones that we give, don't give them to orthopedic patients. Most orthopods will not want them used in their patients because they make wound healing more difficult. And that's a pretty well-studied effect. So last paragraph, 267.
Can I go on?
Yes.
Are these including or excluding acetaminophen?
Including.
Including, okay.
Perioperative NSAID-induced renal dysfunction may occur in high-risk patients, such as those with hypovolemia, abnormal renal function, and serum electrolytes, and so on. So just avoid it. So they talk a little bit about go on the next page, 268, and they'll give you a little blurb about each one. I'm not going to read this, but there's the effects on wound healing and why they say avoid it. People with a sulfonamide allergy, these drugs, some of the drugs should be contraindicated. Contraindications, don't give them to people who are allergic to any of them. If somebody's allergic to aspirin, don't give them the other ones. Okay? Some people feel that asthmatics should not receive these drugs. There's a subtype of asthma, well-defined, very well-defined. It's called aspirin-induced asthma. And there's a subset of patients, we're going to talk about asthma next semester, that get an asthmatic attack if they take aspirin. And they also with the other NSAIDs as well. But if you look it up in a medical book, it's called aspirin-induced asthma. But it's also all the NSAIDs. So if anybody has asthma, most people will not give them one of these drugs. Either because you don't know if they have aspirin-induced, or it's triggered by aspirin or not. Okay, the next page is ketorolac and a little bit about that. And I'm going to let you take a look at this stuff. I can't imagine most of you have not given it or have been involved with it. There's the dosing there. I am dosing for patients less than 65 or older, usually given 30 or 60 milligrams. IV dosing as well. And you can take a look at that. Now, page 270 is IV acetaminophen. This has become very popular in the anesthesia world, and it's used a lot in PACU, especially in shorter procedures, surgery centers, outpatient, etc., but even in inpatients as well. So let's take a look at this. This is from 2011, when it was first introduced into the U.S. It's been around the world a lot. But let's just take a look. It's pretty simple stuff. It's just Tylenol. The FDA has approved an IV formulation of acetaminophen. It's called Affirmav for use in patients greater than 2 years old for the management of pain, either as monotherapy or as long, so you can give less opiate, as opiate sparing they call it. It's an IV formulation. It comes with a little IV bag and so on. There's two other ones available. IV ketorolac, as they mentioned, is there, and then IV ibuprofen, it's called Alar, is also available. So there's three of them available: IV, ibuprofen, ketorolac, and acetaminophen. Pharmacology, the maximum serum concentration after IV is about 70% higher than the same dose as oral. Oh, what does that mean? Yes, thank you. Bioavailability is less orally than it is IV. Right? Terminal elimination half-life is about 3 hours in children, 2.4 in adults. Analgesia occurs in about 10 minutes, reaches a peak in an hour, and lasts 4 to 6 hours. So it's pretty standard. Yes?
So does, what you were just saying, does that mean it works better IV?
Yes. You get a higher blood level IV. So in adults, so there's some of the studies, you don't have to go through it. Let's jump to the next page. There's a little table of the 3 IV drugs that we have available to us. There's Affirmav, and you'll see the IV dose is 1,000 milligrams. That's how it comes. Packaging, it comes as 1,000 milligrams. And you give it as an IV infusion over 10 to 15 minutes, and you're all set to go. The cost, look at that, $10. Cheap. So it's cheap, it's effective, it has minimal side effects. Why not? Yes?
If the bioavailability is higher IV, why is it the same dosing? Wouldn't that cause toxicity?
No, well, no, the toxicity, I'm not sure I know what you mean. You're not going to get toxicity until you get to 4 grams. So they're giving the higher dose IV just because you want an immediate effect and you want a big effect. So you might as well give a higher dose. Because 1,000 milligrams sounds like a lot, but it's not. It's still only 1/4 of the way to toxicity. Is that what you mean?
Well, I'm thinking about ibuprofen because 800 milligrams is quite a high dose and may induce GI bleeding. So giving it IV, wouldn't you be getting like 99% versus if you give it orally, you get a lower bioavailability?
Yes, but without excuse me, without the oral dosing, you have less GI bleeding. So a single dose IV, 800 milligrams, say, of ibuprofen, you wouldn't expect to see GI bleeding. And then there's ketorolac, 30 milligram dose, and so on. And they're all cheap, as you can see, so it does well. Adverse effects, antipyretic effect of acetaminophen, may mask fever. I'm not sure we're too worried about that. In clinical trials, adverse effects were similar to those with placebo, so that's pretty safe. Recommended doses, it has not been associated with hepatotoxicity, but overdose, of course, can cause problems, as we know. Doses, recommended dose is 1,000 milligrams every 6 hours. Can be given directly from the 100 ml vial without further dilution, infused over 15 minutes. So there we go. The conclusion, IV acetaminophen can decrease pain, reduce fever. Given in conjunction with opiates, it can have an opiate. You don't have to give as much opiate. How it compares to ibuprofen or ketorolac remains to be established. Overdose is the most worrisome adverse effect of acetaminophen by any route. That's just a generic statement. Okay? Let's take a break. Okay, let's get started again. Page 283. Page 283. This is a little drawing, and I have a reference on the bottom of the page there. It's from British Journal, 2011. And I just put it in there because I thought they did a nice job of looking at the different points for if you're going to do pain therapy. The different types of drugs you can use, and starting with number 1, NSAIDs and the COX inhibitors, topical local anesthetics. You can do nerve blocks, epidurals, etc. You can give opiates, ketamine, gabapentin, and so on. So they're just talking about all the different drugs you can use in small combinations for the treatment of pain. I just thought it was cool. All right, let's go through some of these figures. Page 284. Overview of the common kinetic and dynamic effects of the NSAIDs. I'll start as usual and the head and move around clockwise. You can get angioedema from an allergy to them, but it's pretty rare. Hypertension, increased cardiac risk. That's the patients getting MIs. They can cause bronchoconstriction in patients with asthma that have aspirin-induced asthma. They can cause a rash and so on in those patients who are allergic. They have an antiplatelet effect and cause gastric ulcers. Anti-inflammatory effect, of course, except acetaminophen. Hepatotoxicity, especially the acetaminophen. The depressed kidney function, impaired bone fusion, antipyretic, and there you go. Those are the big effects of the NSAIDs. The next picture on the next page is the tricyclic antidepressants, and I'll show you them in just a minute, but they are used occasionally for the treatment of chronic pain. So these will be patients taking prescriptions for these TCIs on a long-term basis. And the tricyclic antidepressants are drugs that block the reuptake of serotonin and norepinephrine. That's how they work. And I'll, again, go around clockwise. They can produce sedation, dry mouth, QT, interval changes and cardiac changes. They usually make you gain weight, GI problems, urinary retention. They can cause hepatic problems, orthostatic hypotension. They are antidepressant because of their catecholamine effects and so on. And they produce some analgesia. But as you can see, they got a lot of side effects for the analgesic. Analgesic, nice, but look at all the stuff you got to put up with. And lastly, on the next page, this is gabapentinoid drugs. We'll talk about them in a minute as well. And there's some of what they do. And again, this is chronic pain therapy. That's not something you see in the OR. Just like you don't see the tricyclics in the OR. But anyways, they are anxiolytic, cause euphoria and analgesia, sedation, blurred vision, and dry mouth, peripheral edema and weight gain, constipation, angioedema, confusion, dizziness. That's a lot of stuff to put up with for the effect. However, chronic pain patients get points, they get desperate for any kind of pain relief, and they're willing to put up with side effects to get rid of their pain. And there you go. All right, let's finish off with these key points. And for this part, the key points on page 286. The NSAIDs inhibit the conversion of arachidonic acid to the various prostaglandins, thromboxanes, and prostacyclins. They're generally well tolerated, but distinct toxicities do exist, and patient comorbidities should be considered. Controversy exists regarding NSAIDs in PAP hemostasis. They rarely cause clinically significant antiplatelet hemostatic derangement. Used with caution when other causes of coagulopathy exist. The COX-2 inhibitors, that's Celebrex, the only one of them in the U.S., does not affect platelet function, should be considered when there are other concerns with hemostasis. GI toxicity is really a problem with short-term use, perioperative use. If you're taking ibuprofen for 2 days post-op, you're not going to get GI bleeding, is what they're meaning. But significant cause of morbidity and mortality with long-term use. The NSAIDs are safe and useful adjuncts in the management of non-cardiac post-op pain. COX-1 and 2 inhibitors should be avoided in patients with bad kidneys. Topical NSAIDs can produce local therapeutic effects without significant systemic drug levels, therefore avoiding the adverse effects of oral agents. These are topical creams you buy in the drugstore or whatever else. The next page, 287. Acetaminophen, available in oral, rectal, and IV formulations, is useful for the management of mild to moderate pain, and in appropriate therapeutic doses lacks the toxicity of the NSAIDs. Analgesic properties of the tricyclic antidepressants are thought to be related to the reuptake inhibition of serotonin and norepinephrine. The tricyclic adverse effects include all those we've been through them before. The gabapentinoids bind to the alpha-2 delta-1 subunit presynaptic calcium channels, produce their effects, who cares? Gabapentinoids are structural analogs of GABA. They're approved for post-herpetic neuralgia and partial seizures, for chronic pain patients, etc. Okay, we'll take a look at those in a minute. Now, let's go to the medical letter, and this Drugs for Pain edition is one of their widely popular ones, and they update it every couple of years when something is worth updating. And so this is page 288. I'm not going to go through it all, but it's a way to finish up and summarize everything. So, and I like the way they do a nice job. Their recommendations, of course, mild to moderate pain are the NSAIDs, and the selective COX-2 inhibitor, Celebrex or celecoxib, It's less severe GI problems. For severe pain, of course, we still rely on the opiates. So starting on page 288 with the non-opiates, acetaminophen has no clinically significant anti-inflammatory activity, but it's less effective than the full doses of the NSAIDs, but obviously fewer side effects. Overdose can cause serious or fatal hepatotoxicity in some patients, especially those who are fasting, alcoholics, already burning out their liver, people taking INH for tuberculosis, or enzyme induced. It can develop after moderate overdose even with high therapeutic doses. So continued use of acetaminophen increases the anticoagulant effect of Coumadin, and a dose of a gram for 2 weeks has been shown to increase blood pressure slightly. I'm on page 290. Occasional use of oral acetaminophen during pregnancy is generally considered safe. IV acetaminophen is classified as a category C risk during pregnancy, so don't give it to pregnant women. If they take it at home once in a while for like a headache they can't get rid of and they're about ready to shoot themselves, it's probably okay, but we don't want to use it either. Okay, number 2, the salicylates, aspirin. Aspirin is effective for most types of mild to moderate pain, but now is mainly used as low doses as a platelet inhibitor. So it's mostly for cardiac drug. Unlike the other NSAIDs, a single dose of aspirin irreversibly inhibits platelet function for 8 to 10 day life of the platelet, interfering with hemostasis and prolonging bleeding time. A single dose can precipitate asthma in aspirin-sensitive patients. High doses or chronic use can cause GI problems, etc. And aspirin should not be used in viral syndromes, like if somebody's got the flu, etc., or in any children or teenagers because of the risk of Reye's syndrome. So it's absolutely contraindicated. That's why they give Tylenol to kids. The NSAIDs are mainly due to inhibition of COX-1 and 2, their effect. Single full doses most are more effective than full doses of acetaminophen or aspirin for the treatment of acute pain, especially with inflammation, and so on. Bleeding, second column, page 290. All NSAIDs except Celebrex, and to a lesser degree, Melicoxam, and maybe that's partial, can interfere with platelet function and prolong bleeding time. Unlike aspirin, which is irreversible, the NSAIDs induced antiplatelet effects reversible once the NSAIDs stopped. There's GI effects and renal toxicity. We don't need to worry about that. An increased risk of serious cardiac events such as MI, so turn the page to 291, or stroke has been reported with some NSAIDs, and this is a 2013 publication. You can see the one we read earlier before the break was 2017, so now they've further defined that it's a problem. The risk with Celebrex may increase with higher doses. Like other effects, like aspirin, NSAIDs can precipitate asthma and anaphylactoid reactions in aspirin-sensitive patients. So anybody who's an asthmatic, I wouldn't give any of these drugs to. They may take them, they may not, but you don't know. Pregnancy. Exposure to the NSAIDs during pregnancy or around the time of conception has been associated with an increased risk of miscarriage. The data are weak. They can cause some pulmonary problems and so on. Most pregnant women will not take these drugs. As far as the opiates go, and I'm not going to go through these, we went through them in great detail. So we can skip that part. And if you can read that yourself. I'm skipping to page 293, and there's Demerol, and they mention meperidine should only be used for short-term treatment of moderate to severe pain because of the toxic metabolite. Repeat doses of the drug can cause accumulation of the metabolite normopiridine, which is toxic. Now on page 295, antidepressants, and this is the table on the page shows them. The antidepressant, tricyclic antidepressants, the amitriptyline, nortriptyline, and imipramine have been around for many, 30, 40 years, and were once widely used as an antidepressant, and now they're pretty much used for this reason, treatment of chronic pain. And they list them up there on top. There's their drugs in the types. The epileptics, or gabapentoids. There's gabapentin, there's Neurontin, and pregabalin is Lyrica. I see Lyrica advertised on TV a lot. It's kind of funny. You go into a doctor and ask them to give you Lyrica. It's odd. They must think it works, huh? Anyways, they're used for adjuvants and pain management, and you can take a look at that yourself as well. And then finally, there's a little blurb I put in here, page 297, about treatment of opiate overdose. We know how to do that. You give them Narcan. Pretty simple. But this is from the medical letter in June of this year, because Narcan is now, as we talked about before and saw in that little movie that I showed you last week, that it's becoming widely available in all ambulances and healthcare facilities and in hospitals and clinics and you name it. So they talk about the availability, a number of jurisdictions that now have naloxone access laws that make the drug available to first responders, or just you got an addict in your family. You can get Narcan to take home, just in case you unfortunately find them overdosed or whatever. Give it to relatives and close friends of persons using heroin or taking non-prescription opioids. Laws grant civil and criminal immunity to lay people who carry or administer naloxone, or healthcare professionals who prescribe or dispense the drug. So they want it out there, they want everybody to have it, and so you can give it when you need to give it. Yes?
Since Narcan has such a short half-life, and it says repeated administrations may be necessary, why don't they just give like naltrexone or a longer acting?
Naltrexone's a pill, so if they're overdose, they need to get an injection. Nalmefene can be used, but it's just a little trickier to give. It's not as widely available. So they stick with naloxone, you give it, they'll usually respond and wake right up, and you send them to the hospital in case it's going to occur again. And you're absolutely right, there in the bottom paragraph they mention the half-life of naloxone is much shorter than that of most opiates, so repeated administration may be necessary. So it's a life-saving thing, a resuscitative thing, then you want to get them to the hospital. Look on the next page, this is what I put this in there for. This is their medical letter talking about price. This is pharmacy cost. So look at generic Narcan is what we use in the hospital in the anesthesia carts and so on. It's 0.4 milligrams per ml, and it's $13. The injectable stuff they give the public to carry in ambulances and first responders and so on are those auto-injector things where you just put them on the patient's skin and push a button and the needle goes in and injects. $1,875. That's one expensive syringe, I gotta tell you. Mamma mia. Intranasal, which is still also available, and they use that as well for overdoses. The problem is if they're not breathing, you don't get a lot of, the absorption may not be real good. So they want these auto injectors are obviously the best way to do it. Inject it, try to get them stimulated so they can circulate it around a little bit and so on. So that's $62, but I just was astounded by the difference in price. And it's all because of the injector. They're going to be in Congress pretty soon. The next page is their recommendations for treatment of opiate use disorder, and you can take a look at that. We saw a little movie about it, and it's pretty much the same thing, so I won't beat it to death. They talk about methadone and buprenorphine are the two drugs. Extended release naltrexone is an alternative for highly motivated patients who don't want to take narcotics. They can take naltrexone. It's like antabuse. Alcoholics, it prevents you from drinking and so on. But as they mentioned, highly motivated is the key word there. In pregnant and breastfeeding women, maintenance treatment with methadone or buprenorphine is recommended. And Narcan is the drug of choice for emergency treatment. New laws increase its availability to friends and relatives and first responders. And then finally, on the last two pages, look on page 300. I just stuck this in there because I thought it was kind of interesting. These are all the formulations that the companies have come out with. See, they're abuse deterrent opiates, they're called. What they are is pills that almost all of them have some kind of Narcan in them. So if you take it by a pill, the drug gets absorbed, the Narcan doesn't because it's 100% water soluble, so it still works fine. But if you try to crush it and snort it, or crush it and inject it, then you're injecting the Narcan and it blocks the drug and it won't work. So these are called opiate deterrent formulations. And so if you look, Vicodin, hydrocodone, and hydromorphone is lauded, and they have all different ways. They have other ones that resist crushing. So they're trying to come up with ways to pharmaceutically prepare the drugs to make them safer and less, have less of an ability to mess with and have drug abuse. And that's it. "301 pages worth of talking." I quit. Question?
Can we just look over the 245, page 245 for the Permanente regulation that I mentioned?
Yeah, page 245. I will definitely do that. 240. Oh yes, thermoregulation. The question was, in some of the text or learnings that you have got, some faculty members go that Demerol has an anti-shivering effect. Everybody agrees with that part, but it's because it raises the shivering threshold. And my thing says here on page 245 under thermoregulation and shivering that the anti-shivering effect is due to a reduction in the shivering threshold. So what is it? Increasing or reducing? So I'm trying to deduce this out in my brain, and I think it's this. If you are less able to shiver, that would be a reduction. Does everybody agree with me? I should just say depresses. It'd be a lot easier. But it's a real good question. And I think if you're less likely to shiver, your shivering threshold has been reduced. That means you can be colder and still not shiver. And I know you know what it means, but what should you say? An increase in shivering threshold or a decrease? And thinking it through, I think it should probably be decrease. That's probably not what I told you during the break.
No.
I'm trying to confuse you. I'm good at that. So I would say this is probably correct. It's a reduction in shivering threshold. And so from now on, I'm just going to change the word to depressing shivering. Well, that's a good question. Any other questions?
Is there anything specific that we need to know about the NSAIDs for tomorrow?
Yeah, the NSAIDs for tomorrow, just know that acetaminophen is not anti-inflammatory, but all the rest are all the rest, all three things. That they're contraindicated in renal problems, and bone healing is their issue. The antiplatelet effect is permanent with aspirin, but not with NSAIDs. It worked by blocking cyclooxygenase. COX-1 blockade causes GI issues. COX-2 not so much. That's about it, I think. Just the big picture, you know. Oh, acetaminophen is toxic in the liver if you get about 4 grams a day. I think that's it.
Thank you. Anything on like the tricyclics or the gabapentin?
No, I'm not gonna ask about that. I'm not gonna ask about tricyclists or you know, you learn about those when somebody teaches you chronic pain. I just wanted to mention them. Yeah. Yes.
Page 283.
283. No. Any other questions? Well, it's been a great semester. Thank you very much. Enjoyed it. I think I said my goal was the first day we met was to make you change your mind about the way drug works, think about drugs differently, learn some basic anesthesia pharmacology. I think we've been successful at that. And the best is yet to come. I'll see you January 9th. Bring your Pharm 2 book. Have a great Christmas. And see you later.